Hi, everybody. This is video 5 of the algorithm for the pharmacotherapy of obsessive-compulsive disorder. We are looking at the parameters of an adequate trial of an SSRI for OCD, and we're recommending that you would first titrate to a standard dose, as we defined in video 4, standard dose, not high dose. And for sertraline, for example, that would be 50 to 100. Continue it for 5 to 7 weeks. And we have gotten to the point where you have started an SSRI, and you are proceeding with standard dosing, the dosing you would use for a major depression treatment. And the difference being, though, that it's longer. There's 3 possibilities of what could happen as you're proceeding with this trial. You could get a satisfactory response that is adequate and good enough, and you're ready to maintain the patient. You also could have a partial response. They're somewhat better, but the level of improvement is not deemed adequate or satisfactory. And the third option is you had no response at all. So we're going to discuss each of those options. Let's say they had a satisfactory response with the current SSRI. As noted earlier, only 40% achieve improvement that is satisfactory. There are different definitions of satisfactory. If you go by rating scale, Y-box scores, some will use a 20% improvement in the scale as a good response or satisfactory. Some use 30% or 40%. What's important, though, is if the patient finds it satisfactory and feel they can live more effectively with this improvement that they've had. Limited evidence suggests maintaining improvement for at least 1 or 2 years before considering tapering, and we support that evidence that you should urge the patient to stay on it for 1 to 2 years once they've had this satisfactory response, and then they could consider going off it to see if they still need it. Now, another outcome could be a partial but unsatisfactory improvement. So, in these cases, the SSRI may now be gradually increased to the PDR maximum dose if the patient tolerates it. In other words, we are trying to treat them with the standard dose and see if they can get a satisfactory response to that first before going to the high dose. You don't always need higher doses, and it's better if you can have success at a lower dose because side effects will be less. So you can go up to the PDR max, which would be 200 for sertraline, 80 for fluoxetine, and 300 for fluvoxamine, if tolerated. But how much better are you going to get with this increase? There was a meta-analysis of the dose-response relationships of SSRIs and OCD by Block et al. 10 years ago, and they showed that patients experience a 7 to 9% improvement in their OCD symptoms on the highest dose SSRI. That's probably not a significant difference, the 9 and the 7, but in short, somewhere in that area, 7 to 9%, that's what you can hope for on average for how much more improvement you're going to get from the higher dose. This is the comparison over 13 weeks of 3 doses of fluoxetine versus placebo. And if you can see the graph, you would notice that over the first 3 weeks, there's absolutely no difference from placebo. But at 5 weeks, we start to see a separation of the 3 doses. All 3 are better than the placebo by several Y-box points at week 5. But the 3, the high, low, and medium dose, are all exactly the same. It's only when you get to week 7 that there's a little bit of pulling ahead of the Y-box improvement from the 40 and 60 milligram fluoxetine versus the 20. And then between weeks 7 and 13, things stay pretty much the same. The 3 doses are all actually improving versus the placebo to an equal degree, but the difference between the 3 doses is still only 2 points, maybe 2.5 points on the Y-box, which is that 7 to 9% I was talking about. The third possibility is that you got no response at all. Nothing's happening after 5 or 6 weeks. We recommend getting a plasma level to rule out a number of things that could be going on for why you're getting no response. Number one is non-adherence. Many patients don't take the medications that we give them and don't tell you that they're not taking it. The second reason is that you could be dealing with an ultra-rapid metabolizer of your SSRI, which is present in, depending on the ethnic population you're seeing, could be present in up to 10% of patients, depending on the cytochrome enzyme involved. If it turns out to be non-adherence, then clearly a discussion with the patient will ensue, and either the patient will be now willing to take it or you'll proceed accordingly. If they insist on strong adherence, then the idea of them being an ultra-rapid metabolizer becomes a serious possibility. You may want to get genetic testing to confirm it, or you may want to try a different SSRI at that point, or possibly increase the one you have going to a much higher dose, even beyond the PDR max, to see if you can get the level up and overtake the effect of the metabolic process going on. There is no therapeutic range for treating OCD for any of these SSRIs. The level you're going to get from the lab is the typical levels seen in people on the particular dose you're using. So the lab will say, if you're on a dose of, let's say, 40 of fluoxetine, they get levels ranging from X to Y. So you'll be looking at where the patient is in relation to the typical patient who is getting that quantity of SSRI. And that is useful information, and we recommend it. So the key points of this video are that we are looking at the parameters of an adequate trial of an SSRI for OCD. And we're recommending that you would first titrate to a standard dose for 5 to 7 weeks. And if the patient is on course for a satisfactory response, you can stay on that dose for maintenance. But if it doesn't seem like it's going to be a satisfactory response, even with a little more time on the drug, then at this point, like 7 weeks, they've had a partial response, you could increase it to the PDR max. If they had no response at all, we're recommending a blood level, and a 0 level brings up a possibility of poor adherence, and 0 or low levels also raise the possibility of ultra-rapid metabolizer status.